Although ultimately most of them end up being benign, a lot of them need to be worked up further. And what makes them even more challenging is that the large majority of them are actually in the periphery of the lung. It's actually estimated now that about 1.6 million new pulmonary nodules will be detected every year in the US alone. So the current guidelines recommend trying to diagnose these lesions, going after the primary lesion, staging, and obtaining tissue from molecular testing using the least invasive modality possible, and ideally doing it in a single procedure. Sometimes if you're going after staging, looking at the mediastinum, sampling that alone can secure your diagnosis, and that obviates the need for further intervention. But if not, oftentimes you end up having to go after these peripheral lesions. And within those same guidelines, they recommend actually using electromagnetic navigational bronchoscopy whenever possible to obtain tissue from these difficult to reach peripheral lung lesions. The reason for recommending that is that we know that the diagnostic yield compared to conventional flexible bronchoscopy is significantly higher. Looking at some of the pooled analyses using standard flexible bronchoscopy, sensitivity is as high as 80%, but that's really for central endobronchial lesions. And as those lesions get smaller and move out further towards the periphery, the yield becomes less and less to as little as 14% in the outer 1/3 for nodules that are less than 2 centimeters. The flow sheet that shows you sort of how to work through managing solitary pulmonary nodules, and it's a similar flow sheet if you're working with subsolid nodules as well. And this is from the most recent CHEST guidelines. And this is really just to highlight how all these nodules kind of end up in the pulmonologist's lap and often need to be investigated further. So if you're doing your pretest probability, there's various ways you can do that using either guidelines or using some of these risk prediction models that are available. The ones that end up being low risk, whether you're using less than 5 or less than 10%, are a little bit easier to, to manage. That's usually just using CT surveillance. The higher risk ones, if you don't need any kind of medial sinus staging, they often go straight to resection. But unfortunately, the majority of these nodules fall into this area in between, which is your intermediate or your low moderate risk. And as you follow this flow sheet downwards, no matter which way you go, oftentimes where you end up is where you require this non-surgical biopsy. In addition, even if they are high risk, quite often these patients are not good surgical candidates. They're usually older, they're usually heavy smokers, lots of comorbidities. So oftentimes the surgeons aren't comfortable taking them straight for resection. And so they similarly will require you to do some type of non-invasive biopsy before they risk going forward with the procedure. So with that, I think it's fair to say that the management of pulmonary nodules is really at the forefront of thoracic disease. And with that, there's significant clinical and economic ramifications. So using minimally invasive techniques to assess these and characterize these lesions is really paramount. And this is the challenge that's driving really ongoing technological advancements right now in peripheral bronchoscopy. And since the beginning of the 21st century, the early 2000s, there's really been significant technological advances that have increased the accuracy and improved the user interface of a lot of these platforms. And that's what we're going to talk about a little bit more today. So navigational bronchoscopy, sort of as an umbrella term, is really any technology that's used to help access these difficult to reach lesions. Initially, this really was sort of synonymous with electromagnetic navigational bronchoscopy or ENB. But really now in the last few years, it's come to encompass, it's sort of more of an umbrella term. It encompasses really any kind of peripheral bronchoscopy that's augmented by computer-aided systems. So this is things like EMN, like virtual bronchoscopy using radial endobronchial ultrasound, and also most recently robotic bronchoscopy. So briefly, just to take you through the short history of bronchoscopy. So it really all started in the late 1800s. Alfred Kirstein in Germany was the first one to directly visualize the vocal cords in the proximal large airways using an esophagoscope. And then a year later, Gustav Killian, also in Germany, who sort of got the name of, or the title of the father of modern bronchoscopy, used a laryngoscope to examine the trachea and bronchi of a volunteer, and then later went on to remove a pork bone and 3 other foreign bodies from the main bronchi. Came to the US a few years later, so in 1904, Chevalier Jackson's the one that brought it to the United States, and he actually trained under Killian in Germany, and he developed a direct ocular mechanism that you can see pictured there on the right, consisting of an illumination and suction tubing. And attached it to a rigid esophagoscope. And this is really the prototype of what we now know to be a rigid bronchoscope. And he actually became renowned across the United States for his ability to extract things that were aspirated and swallowed. And there's a museum now in Philadelphia that houses over 2,000 objects that he pulled out of people's airways over his career. And similarly, Kichi Kubo, probably not pronouncing that right, also learned under Killian in Europe. And then he brought bronchoscopy to Japan, which is important for when we learn about the development of the flexible bronchoscope. So in 1962, Shiketo Ikeda He was a thoracic surgeon in Japan. He learned from the techniques that were brought over earlier that century. He was the first one to recognize the potential for applying the fiber optic imaging to bronchoscopy. A couple years later, developed the first prototype, presented in Copenhagen a couple years after that, and people started to think this is something that might be useful. 2 years later, added a working channel to it, and this is what they term as the second revolution in bronchoscopy. 2 years later, they added the ability to angulate it, the U-turn angulation, and that's really the same mechanism that we're using today with our standard flexible bronchoscope. This idea of this is just to give you a timeline of kind of how things have evolved. If you look back into the late 1800s under Killian, that's where the first bronchoscopy was really performed. And then really 100 years later is when we developed the flexible bronchoscope. And there really, besides that, there's just sort of minor advances in some certain tools, some lasers, some stents, some ways to obtain biopsies, but nothing really changed bronchoscopically until really the early 2000s. And then since the development of the first electromagnetic navigation bronchoscope, which is what we'll talk about in a second, there's really been a huge, tremendous amount of investment into technological advancement in this field. And things have really accelerated at a rapid process in the last 15 years. So as mentioned, using standard flexible bronchoscopy, our yield is not very good. It ranges anywhere from 20 to 80%, and the smaller the nodule gets and the further it gets out in the periphery, the yield gets worse and worse. Another factor that's associated with greater yield is what's considered to be the bronchus sign. So that's whether there's an airway that's leading to the lesion that you're going after. And they've found with pooled analyses that if you have a bronchus sign, your yield can be as high as 70% doing transbronchial biopsies associated with brushings. Then the other part that makes things really challenging, besides there being an airway leading to it, is the location. That's really predominantly the peripheries. And we've really attributed that challenge to really getting lost out in the peripheral airways. So the alternative to bronchoscopy, which is still used pretty commonly, is the CT-guided TTNA. So that's when you send your patient to IR and ask them to get a biopsy percutaneously, which actually has quite a high yield. It's pooled at about 90%. The problem with that is that it's also got a pretty high complication rate. So about 30% of those procedures end up with a pneumothorax, and overall 5 to 7 end up requiring a chest tube. If you look at the pneumothorax rates with bronchoscopy, depending on what you read, it's anywhere from like 1 to 4%. And there's really no reports of any kind of major bleeding or deaths associated with bronchoscopy. The other issue with CT-guided TTNA is it doesn't provide you with any staging. So oftentimes, even though you get a diagnosis, you still need to do a subsequent procedure before you can move on with your management. And so that's where this whole idea of, well, maybe if we can see things better, maybe our yields would improve. So that's where navigational bronchoscopy comes in. The one thing that was explored was fluoroscopy, and it's sort of going into the data on this is really beyond the scope of the presentation, but just trust me when I say that all the studies that looked at fluoroscopy showed that really fluoroscopy alone with standard flexible bronchoscopy didn't do anything to improve yields on these smaller peripheral nodules. So then this concept of having real-time guidance and the ability to precisely direct biopsy instruments in a minimally invasive way that led to the development of EMN. So how EMN works is that you use a pre-procedural CT to create this 3D virtual map. And it's really sort of synonymous or analogous to the way we drive using a GPS. It's really a GPS for your lungs. You have this field generated that emits a low strength, and it passes through the patient's body. And then the tool that you're using has a dedicated sensor that when it's put into this field, you're able to use software that can establish the XYZ coordinates of that tool. So the first ENB was developed at Hopkins. It was actually a radiology resident, Stephen Solomon, who started working with this in the late 1990s. And he was building off technology that was already in practice in neurology, urology, ENT, and cardiology. And he helped develop a sensor that could be tracked in an electromagnetic field. And that's what you see a picture of there. He took this sensor and he built one that was actually able to be detected in real time, its orientation and its movement, and it could be superimposed on a previously acquired CT or MRI or fluoroscopy image. He then worked with Dr. Wang, who's of the Wang needle that we use now, and they optimized the registration process, which is the process that you use to align the patient's anatomy with the previously acquired image. That being said, the first commercially available ENB actually came from Superdimension by Medtronic, and they were sort of developing technology at the same time. They actually took technology that was being used in the Israeli defense system. And initially, they took that technology and actually applied it to computer gaming. But then they decided to move beyond that in 1998. They applied it to interventional cardiology. And then in 2001, that technology started to be applied to pulmonology. And then they subsequently added a steerable catheter, 3D image processing, and this ability, the image to body algorithmic registration. What you see on the right there is a picture of what it looks like when you use the Super D technology. So you have your bronchoscope here, then you have your working channel, and then you have your sensor at the end. Once you navigate to wherever it is that you're targeting, this sensor gets pulled out. You have a 2mm working channel, and then you subsequently insert whatever biopsy tool you want to use. And under fluoroscopy, you take biopsy of your lesion. The initial trials were done on animals, and they were successful. They didn't have any complications, and then it really accelerated and being kind of used by physicians. The first trial was actually designed by the Solomon group at Hopkins, and they were about to launch this multi-center trial. They actually had their funding pulled out from under them, and that was actually the end of the Solomon sensor, and nothing really was done subsequently with them. So that's when Super D really sort of saturated the markets. They did 2 small studies. One was 13 patients, the other was 29. They got biopsies in 9 out of the 13 and 20 out of the 29 with a very low complication rate, just 1 pneumothorax in the larger cohort. In 2002, it was cleared for use in Europe. 2004, cleared for use in the United States. 2006 is where you got your first study, and that was done at the Cleveland Clinic. This is just a picture to show you kind of how the interface looks. So you can have multiple cuts displayed at the same time, whether you're looking at axial, sagittal, or coronal. The purple line directs the bronchoscopist towards the lesion. Down here, you have the virtual image. So that's what the software generated for you and shows you the route that you're going to follow. Then here you have the real-time image, and you follow your route, looking at the planar image here, and you get out to your lesion. You pull out the sensor, you insert your biopsy tool, and then under fluoroscopy, you can take a biopsy of your lesion. So that first study at the Cleveland Clinic had 60 patients. There were 54 peripheral lesions, and a little over half of them were less than 2 centimeters. They performed the ENB on 58 of them. The diagnostic yield that they reported was 74%. And they said they got a diagnosis in 80% of those procedures, and they had a pretty high malignancy rate of 74%. Very low complication rate, so pneumothorax in 2 patients. It's not clear whether those required chest tubes or not. Of course, this is very limited data. It's single center, it's not randomized, it's expert-led, but that was sort of all they had until in 2006. Following that study, Super D started was being bought up and started to be used in the sort of the mid-late 2000s. And at the same time, there was other companies also started trying to develop their own technology. Just to give you an idea of how much this technology has progressed in the last 15 years. So that technology from 2006, Super D is now on its 2nd generation platform, and it's on its 7th generation of software. So things have changed quite a bit in 15 years. Just as Super D was developing their technology, there was another group, which is the spin thoracic navigation system by Viren Medical, which is really sort of the other one that has a piece of the market now, and that's the one that we have at Loyola. To date, there's been about 60 clinical research studies published on Super D and about 8 of them on the Viren Medical system, but we don't have any head-to-head trials. So in 2006, Viren came out with their platform, and it's similar in concept, but has some differences that are significant. So the first is that with Super D, you get a CT that was done just within the last 30 days. And that's what you use to generate your virtual bronchoscopic route, whereas here they require a same-day CT, and you get both an inspiratory and an expiratory film. One of the reasons for that is that it's supposed to help account for this idea of respiratory gating. So that's the fact that when you take a breath, the lesion that you're going after is moving. And so oftentimes they attributed some of the lower yield using the Super D technology to the fact that they couldn't account for that nodule moving while you're actively trying to perform the procedure. Viren claims that they can make up for that using this inspiratory and expiratory film. The other sort of bonus that came with that is when you looked at some of the pooled data, doing the same day CT, what they actually found is that oftentimes that nodule is either decreased in size or it's actually resolved. And on 7% of those patients on same day scans, they actually didn't have to go forward with the procedure and ended up deciding this was likely benign lesion, didn't need any kind of intervention. The other thing that Viren can do that Super D can't is the continuous monitoring. So as I mentioned, once you navigate out using Super D, you pull out your sensor and then input your biopsy tool, and under fluoro, take your biopsy. Viren's tools actually also have the sensor. So you get continuous monitoring, whether you're just navigating out or whether you're inputting various types of tools, whether it's a needle, forceps, or a brush, continuous monitoring. The idea is that this also may help eliminate the need for a fluoroscopy. The last thing that's special with the Viren system is that it actually gives you the option of doing electromagnetically navigated transthoracic needle aspiration as well. So if you aren't successful with your bronchoscopy, you can then go and do it transthoracically. This is what it looks like. So A is just the platform itself. This little box here is what goes over the patient and emits the electromagnetic field. And these are the sensors that go on top of the patient's chest that can then pick up where those sensors are moving within that field. What you see in the top right is how that transthoracic biopsy is performed. So you'll have your lesion here in red, and these are various angles of cuts. And then when your tool is lined up properly, these crosshairs will actually turn green to say that you're on the right trajectory to get your biopsy. You'll stick in this needle that has an inner stylet. Once you get into your lesion, you pull the stylet out, and then you can insert various other types of needles to get your biopsy. So there's very limited data on the Viren system as well. The first large study was published in 2016. It was a prospective single center study. They had 24 subjects. They all had solitary pulmonary nodules. They performed the transthoracic needle aspiration in 96% of the cases. They reported a diagnostic yield of 83% for just the transthoracic needle aspiration, which increased to 87% when they used the navigational bronchoscopy, and then went higher up to 92% if they combined EBIS along with that as well. And then you just have some details there about the size of the lesions and the complications. 2 patients required chest tubes. The same year, they published a study that was done in a community hospital, and the idea was how realistic is it using this technology if maybe you don't have all the same resources. So they used the Viren system, but they didn't use radial EBIS, they didn't use fluoro, and they didn't have an on-site pathologist. So they looked at the first 50 patients that had been referred to the pulmonologist by the tumor board. They had ended up with 48 subjects, 61 lesions, and they reported a diagnostic yield of 83%. 78% of them did not have a bronchus sign, and if you can remember, that was pretty significant in terms of being predictive of yield previously, and then 88% did have the bronchus sign. Only 1 patient had a pneumothorax. This is an ongoing trial right now that's going on with Viren Medical Systems called the All-in-One trial. And so the idea is, oftentimes you go and you do an EBIS, sometimes you go do a navigational bronchoscopy, you still don't have a diagnosis, so you send them to IR and you try to get a transthoracic biopsy. And so what this study is looking at is to see if the Viren Medical System can be an all-in-one system. So they're currently actively enrolling patients to see if they can do EBIS, do navigational bronchoscopy, and do the TTNA, all using that system, and what their diagnostic yields are like, complications, feasibility, and things like that, and we're awaiting the results. So up until the late 2016, 2017, we just really had these studies that were single center, that really had limited generalizability, and they usually kind of expert led. We didn't really know much about the safety, usage profile, clinical utility of these technologies, really in a multi-center kind of picture, and just something that would be a lot more sort of generalizable to the population. And so that's where the Navigate trial comes in. It was a prospective multi-center cohort study to evaluate ENB, and they used the SuperD platform. In 2017, they published their 30-day follow-up results, and then in 2019, they published their 1-year follow-up results. So they had a little over 1,100 patients. They claimed successful navigation in 94% of cases. Exactly what that is isn't clear. 49% of them, so almost half, were less than 2 centimeters, so they were small. And then the median distance of the lesion from the pleura was 9 millimeters, so they were truly peripheral lesions. 99%, they had follow-up at 1 month, 80% at 12 months, and we're still waiting on the 24-month follow-up. They reported 12-month diagnostic yield of 73%, so specificity and positive predictive value of 100%, but sensitivity is 69% and a negative predictive value of 56% for malignancy. Pretty low complication rate. And then overall, they conclude that they can get a diagnosis about 75% of cases, and that it's got a pretty low procedural complication rate. So I think it's important to sort of take a closer look at the data in the Navigate trial, because one, just to sort of understand the limitations of this study itself. And I think that this sort of critique is applied really to all of the data that we have for navigational bronchoscopy. So the first thing to consider is that, as discussed earlier with that flow sheet, surgical resection is recommended for nodules that have a high pretest probability, so anything greater than 65%, as long as assuming that they don't need any kind of like pre-op staging of the mediastinum. And then otherwise, you really should just be going after these lesions with navigational bronchoscopy in certain cases where, for example, they have intermediate risk, if they're high risk, high surgical risk, or if the patient or the surgeon themselves want a diagnosis before they decide to resect it. If you look at the patients in the Navigate trial, 59% of them that underwent E and B actually had a greater than 65% pretest probability. And so it just sort of makes you sort of take a step back and wonder, why is this sort of guideline discordant care going on? Is this sort of the typical practice for interventional pulmonologists and how we're applying navigational bronchoscopy, or did they sort of select their population differently that they used for this trial? I'm not sure what the answer is, but I think it's just something to keep in mind. Additionally, it's this idea of diagnostic yield. Some of you might have been wondering when I was reporting those numbers in the previous trials, so the diagnostic yield is this, but what does that mean? And oftentimes it's not defined in the trials, which is really important. In this particular trial, they defined it as a true positive, so they got a diagnosis of malignancy in that biopsy, or they also included true negatives at 12 months. So it was the cumulative of those two. Now, the first thing is that diagnostic yield is highly affected by prevalence of disease. So the more cancers you have, probably the higher diagnostic yield will be, because it's, that being said, in this trial, 44% of the cases were malignant. If you look at some of the pooled analyses from other trials, ENB is really performed in populations where the prevalence of malignancy is actually 65, 70%. That being said, so 44% were malignant. That means that a large part of what they have attributed to be their diagnostic yield is what they called true negative. So then you have to look a little more closely at what did they consider to be a true negative. So they defined a true negative as those that had a histopathologic diagnosis of non-malignant process or an indeterminate one, but were radiographically stable at 12 months. And really sort of the norm now is to follow these things for 24 months before you can declare that something is stable and confidently call them non-malignant. So I think you have to be careful how you treat the true negatives that they're reporting as part of their diagnostic yield. Finally, there was a large registry called the Acquire study that's also sort of beyond the scope of this, but the way that they looked at their diagnostic yield is really looking at the diagnostic yield at the time of the index procedure, which is something very different than what they did here in this trial. And if you used the diagnosis that they secured at the time of the index procedure, their diagnostic yield would actually be significantly lower, be down around 49%. So it's just something to keep in mind when you're looking at the data from these trials. And then finally, sensitivity is 69% and negative predictive value 56% is probably not enough to be confident that when you're doing these biopsies that something's truly negative. So again, something to keep in mind, the limitation of this procedure. Nevertheless, it's quite possible this actually is reflective of current real world use of ENB. So overall, I think it's fair to say that the data is difficult to interpret. Most of these are single centers, case series, or retrospective designs, and they'll usually use experts that are running these studies. The inclusion criteria is quite variable, making it hard to sort of compare study to study and to do pooled analyses. And then the definition of diagnostic yield is quite variable. That being said, if you look at all the data available, you could probably say that diagnostic yield is somewhere in 65 to 70% range. And all the things that have been found to contribute to the challenge of getting a good diagnosis are things like nodule size, the distance from the periphery, the location, so upper lobe, superior segments, where it's hard to sort of angulate your scope towards those areas, and also the lesions closer to the diaphragm that are more affected by respiratory variation. And then finally, the presence of a bronchus sign. So the other part that makes it difficult is that when data comes out, it's usually data on old technology. The technology is evolving so rapidly. So for example, the Navigate trial, which just came out with their one-year follow-up in 2019, SuperD has already upgraded that technology. So the technology that's being used now is not even what they studied in that trial. But in general, I think it's fair to say there's a lack of high quality evidence. This is a picture from a paper that was published in 2015. And the purpose of this is really just to sort of underscore how important respiratory variation is. So what they did is they took patients that were going to be undergoing an ENB and took inspiratory and expiratory CT films and then measured how much the lesions that they were targeting moved between those two films. And as you can see in the upper lobes, it was a little over 1 centimeter, and then in the lower lobes, it's actually greater than 2 centimeters. And then if you think about the type of lesion that you're trying to go after, moving between 1 centimeter and 2 centimeters can be quite significant, especially if you can't see the lesion. So this idea that you can't see the lesion and that it's moving is where radial EBUS actually comes into play. If we agree that the inability to visualize the nodule in real time might be affecting the yield. So the advantage of radial probe endobronchial ultrasound is that you can actually confirm that once you've navigated out, you've navigated to the nodule that or the lesion that you're targeting. The challenge with radial EBUS is that if you don't use it as an adjunct to EMN, you have to be able to get out to the periphery on your own. So that requires a little bit more intensive pre-procedural planning, and you have to remember how you plan to get out there. The other challenge is that the probe itself is not steerable. And so when you finally manage to kind of push it into the airway that you want to get it into, once you withdraw to advance your biopsy tool, you have to hope that you can advance that tool into that same small airway. One of the workarounds that they've come up with is to use a guide sheath or an extended working channel. And so the idea is that this goes out with your radial probe. Once you get to the area that you want to do your biopsy, you pull the radial probe out, your sheath stays out there, and then you can advance your biopsy tool and hope that you're biopsying the same place that you were before. And they've compared using the guide sheath and not, and the yield is significantly higher with the guide sheath, 84% versus approximately 50%. Overall, in a large systematic review that was published a couple of years ago, they found that the yield using the radial probe is roughly about 70%. But one of the significant factors in that was whether the lesion was concentric or eccentric. So it's 80 versus like 30 to 50%. This is similar to the idea of the bronchoscopy on the CT. The other problem with the radial EBIS, unlike using convex EBIS when you're going out to the mediastinum, when you do it in the mediastinum, you can actually see your needle going into whatever it is that you're trying to biopsy, and you're unable to do that with the radial probe. So then there was this thought that, well, we can find a way to combine our biopsy needle with the radial probe. Maybe we'll be more confident going after them, and then maybe our yield would improve. The challenge is you need to come up with some kind of a device that's small enough to get into a 2 millimeter working channel that includes both the needle and the radial ultrasound. And you have to be able to, has to be flexible enough for the scope to be able to bend and get out to those nodules. And then finally, you have to be able to see the needle going into your lesion when you do your biopsy. So that's where this group that published this trial in 2019 tried to sort of solve this problem. So what they did is they developed this hybrid catheter that they combined a TBNA needle with a radial probe ultrasound. And this was purely a feasibility study to see if it would work. They had a little over 20 patients, and they built this hybrid catheter. Mean lesion size was over 3 centimeters, but that's probably not really so important. The important part is they were actually able to navigate out to these nodules, and they were actually able to get adequate specimens for cytological evaluation in every one of the cases. And on top of it, they were able to visualize their needle in every single one of their biopsies, and there were no complications. So really the next step, this is really just a feasibility study, is they need to start to define really what the target population is and start to do more comparative studies and multi-center studies for this. Just to give you an idea of what this looks like, so here it is. So you have your working channel, and coming out of it is your radial ultrasound probe, and then that's your TBNA needle. That's just a rendering of what that tip looks like with your needle just outside of the ultrasound probe. On fluoro, you see your catheter and then your needle just distal to it. And then here on the right, you see the image projected from the radial ultrasound where you can see your lesion and you can see the hyper-echoic area, which is your biopsy needle. So it'll be interesting to see where that goes. Using the same idea that maybe if we can see the lesion, maybe our yields would improve, is where cone beam CTs come into play. So these are a real-time 3D reconstruction of the lungs. And so it's similar to a CT, but it doesn't require as many spins. It just does a 180 around the patient, takes a whole bunch of pictures, and it takes about 4 to 10 seconds. And it gets you a 3D reconstruction as opposed to a fluoro, which is 2Ds. It's already commonly used in IR suites, also for the TTNAs that they perform, and then also dental surgery, orthopedics, neurosurgery, and so on. It's only the last couple of years that it's been explored in conjunction with bronchoscopy. It's a little bit difficult to classify this as a navigational system. It's more really sort of a refreshable static map. It's something that helps you sort of assist both precise localization of the lesion and to help confirm that your tool is in the lesion prior to performing the biopsy. The other thing that it allows for is this new idea, or this new technology of augmented fluoroscopy. And so one of the challenges with fluoro is that, one, it's two-dimensional. Second of all, oftentimes the lesions you're going after don't show up on fluoroscopy. And so what this software allows you to do is to project your image onto the fluoro during the case. And so as you do your fluoro during the case, you can project the image that you got from your cone beam CT. And then it's actually, the lesion gets accurately depicted as you rotate your C-arm throughout the case. Like the radial EBIS, it allows you to accurately localize the lesion, but in addition, you can actually live confirm that your biopsy tool is in place. And as I mentioned, it allows for a non-fluoroscopically visible lesion to now be visible, because as you see in the top right-hand corner, that blue dot is the superimposed lesion on the fluoro that the software is able to take from the cone beam CT. So what you see in the top left corner here is the left upper lobe lesion. It's pretty small. Here on the fluoro during the case, the augmented fluoroscopy where you have your lesion in blue, so you can tell that you're navigating to the right area. They stop the case, they run the cone beam CT again. Here they're confirming that their biopsy tool is actually in the lesion, and then they perform and they get their biopsy. Some of the drawbacks are that you still need to get out to the lesion, so it doesn't really do anything for helping you navigate. On top of it, it's a lot of radiation, so people have to leave the room, or they have to at least have some type of shield in the OR that protects them from the radiation while they run the cone beam CT. That being said, the radiation is estimated to be about the same as what you expose a patient to during a regular IR TTNA or like a low-dose CT for lung cancer screening. The data is super limited for this as well. There's been a few case series, and there was a retrospective study that was presented in an abstract form a couple of years ago. They had 57 nodules, 46 patients. Nodule size was about 1.5 centimeters, and they reported a diagnostic yield of 87%. Again, this was single center, expert user. So really we need more data. But I think we will see that as this technology becomes smaller, more affordable, it's probably going to become more widespread in the bronchoscopy suites. So another major factor that we sort of discussed that's affecting diagnostic yield is the relationship between the lesion you're targeting and the airway. So that's like your bronchus sign, and that's your concentric versus eccentric on your radial probe. And so that's where this idea of bronchoscopic transparenchymal nodule access comes into play. What this software allows you to do is to create a tunnel through the lung parenchyma around the blood vessels and to target your lesion. So the main product that's available in the market is called the Archimedes. They use virtual bronchoscopy, so it's not EMN. And essentially the system will reconstruct the airways and the major blood vessels from a CT scan that was done previously. Then your target lesion gets superimposed on the virtual bronchoscopic view, and then the software will guide you to a point of entry, and sometimes will suggest multiple paths to get to that point of entry of how you can perform your biopsy out into the parenchyma. And the manufacturer claims to get you within 3 millimeters of your target. So how does it work? So you import CT, and the software then will automatically extract anything that's greater than 3 millimeters, any airway. You then manually, in the interface, identify the major pulmonary arteries and the veins, and then it'll extrapolate from there. And then you also identify your target on the CT. After that information is provided, the software will generate multiple suggestions for paths to whatever targets, whether it's one or multiple targets that you identified on the CT. You select your path, and then you proceed. So what you see here is the CT. All the stuff in red are the major blood vessels that have been identified, and in green is your target lesion. And here you see the blue or purple line that's going down, and that's the path that it's suggested for you to get towards your lesion. Here's what it looks like in the virtual bronchoscopic view. So here you're in the airway, and then this brown thing is the lesion that's just outside of the airway. And what you see here with this needle is the point of entry that it's recommending you use to target that lesion. And again, down here is just the path that it's recommending, and the stuff that you see in darker red are the major arteries or veins that are outside of your airways, and then similarly down here. So how does this work? So once you've navigated to that point of entry that it has recommended for you, you go in at the trajectory that it recommends for your point of entry, and you basically, this needle comes out of the bronchoscope, and you create a hole through the airway out into the parenchyma. Once you've created the hole, you then insert this balloon dilator. The balloon dilator dilates a hole in the airway, allowing you access to the parenchyma. You insert the sheath that's got a blunt stylet inserted in it. And once you are out at the lesion, which you do under fluoroscopy, you pull the stylet out, and then that allows you to insert a needle, and you can get a biopsy of your lesion that's out in the parenchyma. This is what it looks like under fluoroscopy while you're doing the procedure. So these purple lines are various recommendations for the trajectory to access your lesion. Here you see the thicker one, which is your sheath, and then through that, you're getting a biopsy of your lesion. So of course, there's not a lot of data for this either. 2015, they published the first human trial. It was again a prospective single-arm trial. What they did was they first went after the nodules using this technology, and then they subsequently, the patient underwent a surgical resection, and then they compared their results. So it was really just a feasibility study. So they had 12 patients. They ended up creating tunnel pathways in 10 of them. There weren't any adverse events. What they found was that the left upper lobe lesions were the hardest to get at because that's where the majority of the great vessels are. So they got adequate biopsies in the 10 that they created the tunnels in, so 83%. And when they compared the histology that they got from those biopsies, they were comparable to the histology they got from the surgical resections. There's actually an ongoing trial now. It's called the EAST-2 trial. It's a multi-center prospective international trial where they're measuring multiple outcomes. So really sort of the diagnostic yield, complications, how long it takes to perform the procedure, and so on. We expect to get the results of this trial in the next couple of years. So kind of summarizing what we've discussed so far, diagnostic yield of EMN is somewhere around 70%. Regardless of what technologies you use, CT-guided TTNA still has a higher diagnostic yield, approximately 90%. The problem is that 5 to 7% of these require a chest tube, and doesn't do anything for you in terms of staging the lesion. The lower yield from standard bronchoscopy was attributed to getting lost out in the periphery. That's where EMN came in to try to navigate out to these peripheral pulmonary nodules, but you lacked direct visualization. You were reliant on an old chest CT. There was respiratory variation, and the nodule location played a big role in terms of whether it was a bronchus sign, whether it was concentric, C-centric, and how peripheral it was. So they combined EMN with things like radioprobe EBIS, the cone beam CT, and fluoro to try to improve their diagnostic yields, but you're still subject to problems with respiratory motion, CT to body divergence, and nodule location. So the next step is now robotic bronchoscopy. So the idea with the robotic bronchoscopy is that it will allow you to improve the reach so you can get out to these more peripheral airways. Additionally, something that it can offer is the ability to lock the catheter or lock the scope in place. That gives you more stability and it gives you more precision, so the argument goes. It's also more maneuverable, so it makes it easier to navigate those smaller airways as you get out to the periphery and get out to those further out nodules. There's currently 2 platforms that are available. One's the Monarch by Auris Health. It got FDA approval in March of 2018. And the other one's the Ion Endoluminal by Intuitive Surgical. And it got FDA approval in February of 2019. So this is what it looks like. So this is the Monarch system. It's got an outer sheath that's 5.7 millimeters, and then it's got an inner telescoping bronchoscope that's 4.4 millimeters. The sheath itself can be articulated 130 degrees in any direction and also locked in place. And then from that can emerge the inner bronchoscope, which can also be articulated any direction 180 degrees, and it can also be locked in place. It uses electromagnetic navigation for guidance, and you have continuous visual capabilities all the way out to the periphery. The way you control it is with this controller, which looks like basically like a video game controller. Here's what the sheath and the bronchoscope looks like. So the light blue is the sheath. It can be locked in this curved position, and then out comes the bronchoscope, which can be angulated 180 degrees in any direction and also locked in place before you perform your biopsy. This is what the machine looks like itself. It's performing a bronch on a dummy. And this is how you control it. So it's literally standing in front of a screen like you're playing a video game with your controller. So there's, of course, not a lot of data available yet. There was one cadaver study that was published in 2018. And what it was doing was to see whether the robot can actually get out further to the periphery than a traditional thin bronchoscope. And what they found on average is that the robot got out to the 9th airway generation compared to the 6th airway generation with the thin bronchoscope. They attributed the majority of that to the ability to lock the sheath in place on the robot and also the increased maneuverability. What they found with the thin bronchoscope is that they tried to advance into those smaller airways. The bronchs started to prolapse into the trachea when they were advancing. There was also a feasibility study that was published in 2018 from a team in Costa Rica, 15 patients, single center. Really just a feasibility study, but they looked at peripheral pulmonary nodules. All of them had a bronchus sign, mean size was 2.5 centimeters. They got biopsy samples, 93% of the patients, and they didn't have any adverse events. And that's really all you can kind of take from that. Then there was one retrospective multi-center post-marketing study that was published in 2019. They had 165 patients. They successfully navigated to 88% of the patients, and 70% of those were out in the outer 1/3. Average lesion size was 2.5 centimeters. 63% had a bronchus sign. They report a diagnostic yield of 69%, and that's actually a conservative diagnostic yield. So what they looked at was true diagnoses at the time of the procedure. Anything that came back as inflammation or indeterminate that didn't have appropriate follow-up was excluded from that diagnostic yield. And for those that had an eccentric view using radial EBIS, they still got a diagnostic yield of 71%. And in the absence of a bronchus sign, they got a diagnostic yield of 54%. So that's significantly higher from what we have with the other technologies. And then a low complication rate. There's 2 ongoing multi-center prospective trials that are called Benefit and Target that we expect to get the results from in the next couple of years. The other technologies, the Ion Endoluminal by Intuitive. So it's a little bit different. It's got a 3.5 millimeter outer diameter that's fully articulating, and then a 2 millimeter working channel that's also able to articulate 180 degrees. What's different here than compared to the Monarch is that it's got this, they don't use EMN, they have this shape sensing fiber technology, although they don't really tell you what that is or how it works. But the idea is that it can basically provide constant feedback and allow you to have both positional and shape feedback on what's going on with your bronchoscope. It also has an integrated vision probe, so you have full navigation or visualization all the way out to wherever you're going. But once you get out there, you have to pull that out to insert your biopsy tool. Another difference is they have this custom designed needle called Flexision. And what's really neat is that this thing is actually able to bend. So even if you have a big curve on the tip of your bronchoscope, you don't have to straighten it out to advance your biopsy needle and then hope that you can get it back in the same place. They can actually maintain that curve, and then the needle is able to flex and then come out sometimes even perpendicular to the airway. Your console allows you to see whether you're using radial EBUS, fluoro, live views, everything's displayed on the same console. Then the other feature that it has is what's called the cloud biopsy. So if you're sitting there taking multiple biopsies, and then at one point your pathologist tells you that biopsy number 4 was a good biopsy, the robot remembers exactly what that trajectory was when it took that biopsy. And if you need more tissue for molecular testing and so on, you can then use that exact same trajectory and know that you're getting better quality samples. Up here in this picture is the picture of the needle that can flex. This is how you control it. And this is just a picture of what the setup looks like. Here's the bronchoscopist performing the procedure, and that's what the robot looks like. So again, not a lot of data available. There was this one study that came out in 2019, also a feasibility study, 29 patients, lesions were pretty small on average, 12 millimeters. A little over half had a bronchosine, about half had eccentric views on radial EBUS, and they were able to get samples in 20 out of 29. So they reported diagnostic yield of almost 80%, no pneumothoraces. And what they attributed the increased diagnostic yield to was both the ability to visualize the peripheral airways, to be able to lock the catheter in place, and then the fact that the needle could be deployed perpendicular to the airway toward the lesion. There's an ongoing trial right now called the PRECISE trial. It's a prospective single-arm but multi-center study. There's 6 institutions across the United States that are participating. Their goal is to enroll 360 patients. They're measuring navigation, biopsy success, and safety. And so they published their early result, or not published it, they presented an abstract form at ATS in 2020. So it's the first 70 patients. There's 74 nodules. The size in axial was 18 millimeters on average. Distance to the pleura, so 57% of them were less than 10 millimeters to the pleura, so they're truly peripheral lesions. And they report successful navigation in 98% of them. So and they say successful navigation means within 2 centimeters or whatever their pre-planned target was. They're not reporting any adverse events so far. So what their conclusion is that it appears safe and that the results are encouraging, but we're awaiting all the analyses and diagnostic yields and so on. And that's just a picture from actually one of the bronch suites at Mayo. And they're one of the sites that are participating in this study with the Ion robots. So that's something that I'll hopefully get to participate in as well next year. So overall, the strength and the limitations. So it looks like the robot's probably more precise, has increased maneuverability and reach, and the ability to lock the catheter in place, often in a curved position, is likely to facilitate the deployment of the biopsy tool on the target. Limitations, so there's no tactile feedback, although they both report that they give you pressure grades. So they'll let you know the pressure is increasing as you push into the smaller airways and so on. And it's not really clear what the learning curve will be. Some say that it's harder for the older generations, and maybe it'll be easier for younger generations because they have more experience playing video games. And then the cost, it's not clear what these things are going to cost, but you can expect they're going to cost quite a bit. And then it'll really be figuring out whether the benefits that they give you are really worth the extra expense. So overall, for a conclusion for navigational bronchoscopy, given the increased use of CTs and lung cancer screening programs, the incidence of peripheral pulmonary nodules is likely to continue to increase. Navigational bronchoscopy is a useful tool for accessing and sampling these lesions, and there's really multiple technologies available. The evidence is limited, and it's predominantly case reports and single center retrospective studies, and there's really a need here for better designed multi-center comparative studies. There's also another role for navigational bronchoscopy, which is in the fiduciary placement for things like SBRT, dye marking for surgeons for resections, and there's evolving technology for ablative therapies that in the future might be performed using navigational bronchoscopy. So it'll be interesting to see how things move in that direction. But overall, I would say it's an exciting and rapidly evolving field, and it'll be interesting in the next few years to see where things go. And these are my references. And that's it.
Thanks, Mike. I am overwhelmed by the amount of technology that's currently available, and I literally knew that there was navigational bronchoscopy and EBUS, and that's it. Oh, maybe radial, I knew about that too. But so what do we have here? at
We have
Loyola?
the Viren system.
We have the Viren navigational bronchoscopy.
Yeah.
And that we have obviously EBUS, but we have the radial probe.
We have the radial probe. We have fluoro, which you probably know about.
I knew
And we have Viren. Yeah.
Okay.
Whether Dr. Goles plans to buy anything else, I don't know.
with all his millions of dollars.
Yeah.
So, and then tell me, how am I supposed to determine who needs a navigational bronchoscopy versus radial EBUS, or do I just send everything to Jess and Amit and have them figure it out?
Yes, I think probably a big part of it is the user. And so it's really, what are they comfortable using? What are they more familiar with? And what, in their experience, do they think would be the best modality for accessing that lesion in particular? I don't think it's easy to say, because especially because there's not a lot of comparative trials to say these lesions in this area, you get better yield using this technology. That's one of the big problems. So I think it's really just sort of the operator's preference, really. It's my impression.
But if you have but you're still saying that if we have a peripheral lesion, right? And let's say you have a peripheral lesion, and there's no hilar or mediastinal lymph nodes, then the yield is still better to do a CT guided biopsy, even though you can't stage, right? But you
assuming it's in a place that the radiologist think they can get at, and that the patient's not at high risk for complications.
Okay.
Yeah, I'll just comment on that, and I have no problem saying this. We don't have CT guided biopsies are poorly compensated, and when things are poorly compensated, people have less, as physicians, they have less interest in doing things. And having had experience throughout the area, I can tell you in general, our radiologists are not that interested in doing CT guided biopsies and try to beg off of them. And so the yields in some studies are 90%, but that yield decreases as the further in you go to a nodule. Further in you go from the periphery, from the pleura. And as you go deeper, then your risk of pneumothorax increases. So I would say that your yield from a CT biopsy is anywhere from 80 to 90%. And then if you're behind a rib, which we often see, which I do not fault the radiologist for, or if you're crossing a pleura, if your access point requires you to go through the upper lobe and lower lobe pleura fissure, then they'll often refuse because of risk of pneumothorax, which I also don't fault them for. But they're also not the most aggressive because they just have other interests. So you have to know your local practice to know if that's really viable or not.
Okay.
And then when it comes to staging, you also have to know your surgeon. Some surgeons will say, I want the mediastinum cleared no matter what. And some of that will be based on lesion size. If you have a 2.5, 3 centimeter lesion, they'll still want the mediastinum cleared. So then you may take that as an opportunity to clear the mediastinum and then try to biopsy the lesion while you're there anyway.
Okay.
So I have a question. My great presentation. And yes, I think like Emily, I knew those 3 things existed, and that we had VRAN. I knew that too. In the studies that you've looked at, you said the diagnostic yield was 73% with some variations in how this diagnostic yield is defined, right? But only about 46% of these were malignant. So you go in and you might get inflammation, or you might get actual, a benign diagnosis. So are there studies looking to say where the procedure actually changed management? In the sense you were planning to just go and follow these with serial CTs, and no, now you suddenly came and, it was PET negative, and the patient wanted to know, so you decided, they decided to go and do this.
So I didn't come across anything. I think that's one of the limitations of the data. Probably the biggest data set for these sort of types of interventions is the Acquire study, the Acquire registry, where they had multiple sites across the country and they looked at biopsy yields for various techniques. But there wasn't standardized what techniques they decided to choose. And one of the biggest sort of criticisms of it is that there's no follow-up for a huge chunk of the patients that they included in the study. And so it's not really clear what those lesions actually were and what they decided to do with it after they got a negative biopsy or an indeterminate result. So I don't think I didn't come across anything that had anything concrete like that.
But Amit and Jessica, you must have come across cases like that, right? Like since you see a lot of these?
Yeah, the reason that you don't have robot data right now is because they're trying to do it properly, where they follow the patients for 2 years post-procedure for their negative biopsies so that they can calculate a true diagnostic yield.
Right, but in your practice, like in so far in all the ENBs that are, in going after the nodules, like where before ENB, where I would have said, okay, we can make the diagnosis and you're too high risk for surgery and it is PET negative, I'm just going to follow this. But now we have the option, to reduce patient anxiety or, to offer other therapies, you could go after and get a diagnosis. So how many times have you seen like a PET negative nodule turn out to be cancer, and that would have changed, like they got chemotherapy now or something else?
So that's an important point. It's low. It's probably less than 10%, but it's not zero. And what has changed over the last 5 or 10 years is the amount of empiric SBRT that we'll give. So if we see a lesion that continues to grow and somebody's high risk, just give SBRT. What's the problem? Like the number of complications that we get from SBRT are minuscule. And so if it's high risk, if it has high risk features, we'll just give radiation. And over time, our radiation oncologists have become liberal is not the right word, but they're much more open to doing it if you can make a case for it. And most of these patients, if you have a peripheral lesion, aren't going to get chemotherapy because it's a peripheral lesion. So you're going to treat that with surgery or SBRT. It's stage 1 or an early stage. And I think that goes back to what the role of ENB is. A lot of this technology is very sexy, but it's time intensive and very expensive when you're talking about cone beam. Not every hospital is going to have that. So you're going to get data that shows that the Mayos, the Clevelands, and a handful of other centers are going to say, we can get 95% yield on these, but that's not the real world, right? That's not how 1 million patients are going to get treated every year. That's how 10,000 patients are going to get treated every year. So it's important technology, but it's really not at a stage that's widely applicable. A variant system costs around $100,000 to $150,000, and a robot is $500,000 or $600,000. Not to mention the disposable costs and the support, which they don't tell you about. Then, so the question comes, well, how many patients are you really going to treat like this? This ENB is not the same as EBUS in that almost, many of your cancer patients are going to require EBUS for staging.
Right.
I don't see that many patients requiring ENB for a diagnosis of a nodule. What these guys really want to do with ENB is, and Monarch is owned by Johnson & Johnson, which has an ablative technology. They want to get a catheter out to these peripheral lesions and then prove that you're there in real time, not virtually, but in real time, and then ablate that lesion and say, look, now we're doing therapeutics because therapeutics pays more and is, ideally you can get a biopsy, prove it, and treat it all at once and avoid other treatments. I think that's a high bar. I think it'd be great if we can do that, but SBRT at 5 years is about 90% effective. So it's really a high bar to say that we're going to get there in the next 2 or 3 years. I do think robots are going to be more widespread, but it's only going to be at institutions that can afford it.
Great. I just want to say how much time has elapsed. I think it was like 10 years ago that I went to a Super D something in Minnesota, and Dr. Vandergraaf started doing the Super D ones at the VA, taking 2 hours, and we would stay there with him trying to, as he did. So another shout out to Dr. Vandergraaf. Thanks.
Any other questions or comments?
Out of curiosity, you showed in the Navigational that a lot of people with kind of higher.
Okay, all right. Well, thanks everyone. Thanks, Mike. That was great. Very detailed and informative. So thank you so much.
Thanks.
All right. Bye, everyone.